Welcome to Black Health Matters. I'm Darryl Armistead, your host. This episode is a Zoom recording of Howard University group session led by Dr. Clive Callender.
There we go. Okay.
So we're going to talk. We are going to try and understand the current allocation scheme for liver transplant. Understand some of the currently identified barriers to liver transplantation, and explore some opportunities to mitigate the disparities in liver transplantation. So, liver transplant is still relatively new. The first successful liver transplant occurred in 1967 and was performed by Dr. Starzl at the University of Colorado. Dr. Starzl subsequently moved to Pittsburgh and developed their transplant center. And I think, if you talk to most of us who are in transplant, all of us can kind of trace our lineage back to Starzl or one of the other very early pioneers in transplantation. So the liver transplantation is the standard care for end-stage liver disease. Organs are a constrained resource, and there are obviously the disparities in the evaluation, the access, the listing, as well as outcome for transplant. And I think a lot of these go back to the systemic problem of disparities and problems with access and the evaluation of patients. So if we take nothing else away from this talk, I think the most important thing to remember is organ donation. Organ donation is kind of the most important part of what I do as a transplant surgeon. Without organs, we can't change lives. And there are lots of misconceptions related to organ transplantation. There's lots of disparities related to organ transplantation. I think the most important thing here is on this driver's license that has Michigan on it, where my home state, is this self-designation of the donor. So, before you ever need or before you're ever even considering being evaluated for a donor, to go through and talk to your family and tell them, hey, this is something, if my life is over and there's nothing else that can be done to save my life, I would like to give the gift of life to somebody else and to pass that and to pass my organs along. And it's not a matter of, don't let people rule themselves out because, well, I have diabetes or I'm on dialysis or all those other things, because we use donors who are on dialysis. We use donors who are in their 60s and 70s. We use donors with all types of different problems. The most important thing is to be evaluated, if you are in a situation where further care for you is futile, is to get one of these organizations, whether it's in Alabama, it would be the Alabama Organ Center. In Maryland, it would be Living Legacy. Around the greater DC area, it's Washington Regional Transplant Community. One of those organizations to come in to evaluate your organs for potential transplantation. People have been dying for thousands of years. It's only been the past 50 or 60 years that we've actually been able to give families some, although we don't give them their loved one back, some hope or some hope that somebody's life, their death wasn't futile, and that they could help somebody else as their last act.
Question real quick.
Uh-huh.
Yeah, I have a question real quick. When you're talking about donation and talking to families, are you talking to them both about giving whole organs when there's nothing else you can do for a patient, or are you also talking about partial liver donations?
Well, so I think that I think it goes hand in hand, because I think giving a whole organ at your time of death really doesn't impact you as much. I mean, there's no real downside to that. Whereas like giving part of your liver in life, or it being a donor, a kidney donor, like my sister was, their college roommate, or being a partial liver donor to some of our patients have been when I was at the University of Maryland, and also, as they used to do at Georgetown. Those are things which, there's risk associated with that. But I think having that conversation with your family, whether, even just about end of life care, I think all those things are really important, because, but just that way people aren't questioning, because it's a very stressful time, and the easier you can make it for people, I think the better that it is. So in in 2018, there were around 8,200 liver transplants performed. You can see here that as people are put on the list, what happens to them. The majority of people are actually, the majority of people who are either removed from the removed from the list over time. A lot of people, they die while they're waiting for organs. Patients do undergo transplant, but a lot of people are still waiting at 3 years. And so with liver, it's a little bit different than kidney, where you don't really have a dialysis or a way for people to sit and wait on the list. It's just a matter of you wait to become sickest, which is different from the way in which kidney is allocated. Kidneys are allocated or given to people based upon how much time they're on dialysis and how long they've been waiting. Livers are given out to patients based upon how sick they are. So we transplant the sickest first. This slide here is kind of showing overall transplant rates going back to 2006 up to 2018. We see, though, is there's consistently live donor transplantation is something we're always talking about. I'm sure Dr. Callender has heard more talks than he's wanted to over time about live donor liver transplantation, but it's really it hasn't taken off very much because of the risks associated with the donor. But we can see here that over time there has been an uptick around 2012 with increasing deceased donor transplantation. And so the way in which it works is for allocation is we transplant the sickest first. And the final rule, which is something the government, DC is very familiar with the government. The government has come up with this final rule saying how, where you live shouldn't affect it. It should be fair and all these other things. And there's been a lot of concern over that, especially when high profile people get transplants. Like, in the late 90s when Mickey Mantle got his transplant. And one of the other important parts of the organ allocation is looking at candidate assessment. How do you determine who should be a candidate for organ transplantation? So the model for end-stage liver disease score is the way in which we categorize patients for transplant. We utilize it's the 3-month. It was initially developed to predict 3-month survival following a transjugular intrahepatic shunt. The score ranges anywhere from 6 to 40, but the nice thing with the score is it's completely objective. It uses all laboratory values. It doesn't matter as far as it doesn't look at things that are subjective, like how much ascites patients have, or how encephalopathic, or how they're thinking, or any of those things. It's all objective. And actually, when it comes to for African Americans and minority groups, it's actually been helpful. It has increased the amount of transplants that have occurred. It's also increased the amount of transplants that occurred because of the allocation scheme. There's not an effect if you were referred into your transplant center late. There's no real effect as far as, somebody else was sent in early, so they're further along on the list than I am. If you get sent into our transplant center today and your score is 40, you'd go to the top of the list. If you were evaluated 3 years ago and your score is 15, you're still wherever 15 is at on that list. So there's no real advantage to early listing. There's advantage to early referral because that way you're being seen by specialists and you're being taken care of better, but there's no real advantage to early listing. So we can see here the majority of the median months to liver transplant for waitlisted adults is around in 2014. If you had a MEL to 15, you were waiting a little bit over a year. But that's decreased over time. Now they're waiting around 8 months or so. And the thing is, people's scores, they move along. It's not a static thing. It's something that is definitely dynamic and changes, depending on where their labs are at. So, and then the way in which it works is, so we list people based upon their blood type. And then depending on what blood type they are and what their score is, then that determines who gets transplanted first. And ties in this score are broken based upon wait time. So if you had 2 people who had the same blood group and had the same score, that the person who was on the list longer should get offered that organ first.
I have a question.
Yes.
Can you explain the MELD score, what does that mean exactly?
So the MELD score is the Model for End-Stage Liver Disease score. It's made up of a number of laboratory values. The laboratory values it's made up are based upon the bilirubin, which is a marker of your liver function, the INR, which is a marker of, also a marker of your liver function, but it's something that we follow when we're looking at clotting, because most of the clotting factors are made in the liver. Is also based upon your creatinine, because when the liver gets sick, other organs also get sick, and so the creatinine was found to be a useful marker in this. And then recently they've also added into your sodium score. Now, when we look at adults who are who's dying while they're waiting, that was a big deal. You can see out here in 2006, back in 2006, you had patients with a high MELD score who were dying at a higher rate than patients with a low MELD score. And what's happened over time is when you look at 2018, we've actually decreased the death rate, both for the people over with a higher score as well as a lower score. And some of this is due to the increased sharing of organs. Now, one of the problems that does exist, there's been recently, it's been addressed through changes in policy, is that depending on where you live, really could dictate how or when you were getting an organ. So you can see here the patients who are living on the darker purples represent a higher median score at transplant. And so patients who are living on the coast, whether the West Coast, California, or on the East Coast, specifically kind of New York area, and even here in the Mid-Atlantic, we're getting transplanted with a higher liver sickness score, meaning how they had to get sicker prior to transplant as compared to patients who were living like here in the Deep South or Florida or even parts of the Midwest. And people were like, well, that's not fair. So what could we do to increase the amount of sharing and to even it out? Because, for example, you have patients down here in Alabama, where I came from, who were getting transplanted with a median MELD or an average MELD at transplant in the mid-20s, whereas patients on the coast in California or in New York City were not getting transplanted, their score got to be 35. And so one of the ways in which people did deal with that was that you had patients with resources or with money who would migrate to centers where they had lower scores. For example, if you remember in the early 2000s when Steve Jobs was transplanted, he didn't live in Memphis, but he did move to Memphis in order to have his transplant, because he had better access to organ transplantation there. And as we know, when we look within the African American community, we oftentimes don't necessarily have those same resources to fly all over the country for our medical care. And that's one of the other things that led to the program here at GW, is that is increasing access to transplantation. So we can see here over time again how no matter what the diagnosis was for that got you to transplant, there has been a decrease in the death on the wait list, which is good for patients. And we can see what we do see though is over time we've seen a difference in who's getting transplanted or what diseases people are needing for transplant. What has happened is this triangle kind of represents patients with what we call non-alcoholic fatty liver disease, or liver disease is kind of related to the metabolic syndrome, which is hypertension, obesity, and hyperlipidemia and diabetes. Patients with that indication have actually went up, whereas hepatitis C, which used to be the #1 indication for transplantation, with the recent advances in hepatitis C treatment, is actually decreased. The other thing that I think that we'll continue to see is an increasing trend in patients getting transplanted for alcohol, or for alcohol-related liver disease. And I think that's for a number of reasons. One, I think the transplant community has decided that alcoholism is a chronic disease, and is not something that we should just say that people they drank and so now they have liver disease and how it's their fault. And the other part is, I think that especially the past 2 years with the pandemic and the social isolation, I think we've seen an increase in the number of people who are drinking and the amount of problematic drinking that we're seeing. So this slide, which is a little bit busy, kind of shows all the steps that are necessary to get from a patient with liver disease, here, all the way to becoming, getting transplanted and being a recipient. And where I think, my research in the past has really focused on is kind of this step: patient knowledge, attitudes, cultural and spiritual beliefs, and then the transplant evaluation. Because we will never be able to transplant everybody. There's just not enough organs for everybody to get a transplant. But everybody should have access to high quality hepatology care, and everybody should have a fair shot and a fair evaluation that takes into account all the nuances of their healthcare, their values, their beliefs, in order to see if they would be a reasonable candidate for transplantation. So equal access to the list, but not necessarily, there's no way in which we'll ever be able to transplant everybody unless some of the technologies we talk about further on, unless they really work, that's just not where we're at. So this is a paper that I was the senior author on from back in 2019, which looked at the ethnic and age disparities in outcomes among liver transplant waitlist candidates. And what we found, or what prompted our question, was over time, there's been a 2.5-fold increase in the number of liver transplant recipients over 65. And then there's currently no consensus on the upper age limit for transplantation. And depending on what center you looked at, there was definitely variation in transplant rates amongst the patients over 65. And I think that the transplant evaluation process, as much as we try to make it to be objective, it can be a very subjective thing. I've always been accused by my partners of having a soft spot for teachers. So if a teacher comes in, there'll be or retired teachers, a teacher or retired teacher comes in to be evaluated for transplant. In my mind, although maybe not necessarily openly, in my mind, I think I'm always thinking, well, how do I get this person transplanted? Or you get somebody who reminds you of your grandparent or your uncle or your brother. How do you get that person transplanted? Well, within the transplant community, there's not a lot of transplant providers who necessarily look like us. And so, sometimes having somebody who looks like you, who understands the nuances of the barriers to care in your life, I think that's really important. The other part of it is how I've had patients who have come to me, African-American patients have come to me who would refuse even to be considered for transplant because they've read somewhere how African-Americans have poor transplant outcomes, or they have poor responses to hepatitis C treatment. So again, I think having providers who understand some of those cultural barriers and understand some of those things is really important to improving it. To improving outcomes and improving access. And what we found is, despite having a high prevalence of liver diseases among African-Americans, African-American transplant candidates accounted for a fraction of the patients on a transplant waiting list. UAB in Alabama, 14% of our liver transplant referrals were African-American, despite the fact how we lived in a state with a baseline population of around 25% African-American. So there's obviously there's a disparity that exists there. The disparity, I think, was primarily in the referral of getting patients to us. But again, I think that there's a disparity that exists. And so there's opportunity there to improve outcomes for everybody. So, our aim was to evaluate the impact of age and race on transplantation, mortality, and waitlist removal. We looked at within a national cohort of patients. We looked at younger white, which younger and older were defined based upon age 60, just for us to get numbers that kind of worked out. And what you can see here, without going into a lot of detail, is how the majority of the patients were Caucasian, whether older white or younger white, with the African-American patients here in purple and in this kind of orange, representing probably around 11% of the population of patients who are being transplanted nationwide. So again, there is a disparity I think there's a disparity that exists in transplant access in transplantation among African Americans. So we have already kind of covered this. What we found, though, is how older African Americans were less likely to receive liver transplant than older whites. Older transplant candidates had a lower incidence of transplantation compared to younger candidates. And then younger whites, as well as both older whites and older African Americans, were more likely to be delisted while they were on the wait list. So they would be listed for transplant, and then for some reason, whether it's progression of disease or they got too sick, they were likely to be removed from the list, and that was a terminal event in most patients. So again, I think, this is, again, back to the pathway, how there are multiple steps in the pathway and multiple areas in which we can intervene upon to increase, to improve outcomes. So, we have to, within the transplant community, we have to remember that organs are a constrained resource. We want to avoid feudal transplants, and geographic, depending on where you live, these disparities, they definitely exist. So the migrated transplant candidate is something that, it's related to the fact how patients can be listed in more than one center in order to overcome regional organ availability and disparity. And around 3.3% of patients were multi-listed. And what they found when they looked at this was it was mostly white, older patients with private insurance, a higher educational level. And despite this patients traveling further, the post-transplant mortality was the same. And so they found how a lot of patients were leaving this study was actually done out of MGH, but it showed how patients were leaving an area with constrained resources and going places primarily to the deep south in order to get organs. And so, which I think this led to the change in the allocation system, where they really wanted to move organs instead of moving patients. In the interest of time, we're going to kind of just keep bumping through some of these slides a little bit. You can see here how these patients who migrated had lower scores at the time of transplant versus the patients who stayed at their home center. And like we talked about, most patients traveled around to region 3, which is the deep south. The average distance travel was around 1,000 miles. And what you have to keep in mind with that is how, a lot of us, it's getting just to a center, even in your city, is hard. So trying to travel 1,000 miles to get to someplace would be is almost impossible. So, this is data from a VA study, and they found how deficiencies at the referral level, so providers' attitudes were related to disparities in patients getting transplanted. And so after adjustment for age, alcoholic liver disease, and hepatitis C, patients who were being evaluated and sent for transplant were less likely to be African American than white. And so I think this is something that we all know, how depending on what your provider thinks during that interaction can definitely have a detrimental effect on the care which you receive. And I mean, this just keeps going on, talking about kind of the same thing. And a lot of times patients were not referred based upon history of a prior compliance, where they lived, and then whether or not the physician could empathize with the patient. So obviously some of these things are subjective, and and sometimes compliance can oftentimes be rooted back to social support and your ability to get someplace, right? If you can't get a ride to clinic on the day in which your clinic is scheduled, that definitely affects your compliance with showing up for that clinic appointment. And so taking the time to actually understand that is really important. And lastly, I want to just quickly talk about alcoholic liver disease. It's a spectrum. We're seeing around 20,000 plus deaths related to alcohol yearly. It runs the spectrum from simple steatosis to alcoholic hepatitis and cirrhosis. There are limited options for patients with alcoholic hepatitis. The transplant community has definitely changed its attitude towards it, because of we used to be everyone had to wait 6 months, and they're finding how waiting 6 months doesn't really do a whole lot. And so what we're really trying to do, and what we're going to try and do here at GW, is to make sure we use our social workers to really assess patients assess their risk of going back to problematic drinking. If you look at all patients who've had a liver transplant, around 20% of them go back to drinking, but only 10% of them go back to problematic drinking. And so what mechanisms can we put in place to make sure that, one, patients with alcoholic liver disease, specifically though African-American patients with alcoholic liver disease and low socioeconomic status patients with alcoholic liver disease, that they are fairly evaluated. But then also, once we find that risk, that risky behavior, what can we do in order to, in order to make sure we have the framework in place to help people to be successful? Because like what one of my former partners at Maryland used to say is, how we can fix the liver problem with a liver transplant, I can't fix the head problems that got you into problematic drinking. So again, we talked about this already, how the length of abstinence prior to transplantation is controversial. It really hasn't made a difference, but you can have really good outcomes following transplant for alcoholic liver disease. And then lastly, the last thing I wanted to talk about is again back to the organ shortage. And I think this is really the importance of organ donation, as well as the self-designation of your as being an organ donor. And then lastly, ways in which we can increase the increase utilization of organs. This is a pump, the Transmedics pump, which is actually sponsored by I think it's even owned by partially by United Therapeutics, which is right there on 29 coming through Silver Spring. This is another pump here. This is the Organox pump. It's a pump which I've actually had experience with. Again, where instead of cold storing organs like what's always happened in the past, you put the organ on the pump with an oxygenator, and you can pump warm blood through it, and you can actually see if the liver is going to work. And that's really important, because I think that once we prove that the pump works, then we can look at ways in which we can take organs that are marginal and potentially use those in patients. And then lastly, I think, in the news, the past couple months have been extraordinarily exciting. From back in September, when Dr. Montgomery at NYU did the first pig to human transplant as a proof of concept, to up at University of Maryland, where Dr. Griffith did the first pig to human as with the heart, and the patient supposedly is still doing very well. To again, my former colleagues, this is Dr. Jamie Locke at University of Alabama, doing again another proof of concept, pig kidneys transplanted the exact same way we would normally transplant human kidneys, utilizing genetically engineered pigs, again, in order to expand the organ transplant pool. And I wouldn't dare ask Dr. Callender, but I'm sure that over the course of his career, how this has been the holy grail of transplantation. Whenever we can figure out xenotransplant. I can remember sitting in a grand rounds, probably five or 6 years ago, and Gil Diethelm, who Dr. Callender just brought up, was a former chair at Maryland at University of Alabama. He stood up and said how xenotransplantation was going to be the future of transplant. And I think that's a fair statement. Then he kind of went on, and people were like, he's just old and senile and has Alzheimer's, and he didn't know what he was talking about. But obviously, Dr. Diethelm knew that, and the University of Alabama had put a fair amount of resources behind it for many years. And hopefully, this is the future, because then all of a sudden, I think some of these disparities will still exist, but there'll be different disparities related to transplantation. So with that, GW is opening a liver transplant program, probably start listing our first patients in the next few weeks. We're still awaiting regulatory approval. But our goal at GW is to be the most patient-centered liver transplant program in the region. One of the things that can't be overstated is access. And I think the fact here, how you can see a metro line where you can come in on the metro train into our center cannot be overstated. And I also think the fact how you have currently 3 African-American transplant surgeons in one predominantly white transplant institution cannot be overstated. And then we have a fourth partner probably coming late late 2022 who's Hispanic. So obviously, we are putting a lot of money or a lot of effort into making sure that we are addressing some of the disparities, especially when it comes to minority populations, and at least making sure that we can have a fair evaluation for those patients. And with that, I'll open the floor to any questions.
Thank you very much for a very excellent presentation. It's wonderful to hear that you have another program that's going to be doing liver transplants, because having competition is good for everybody, and especially when you have a team that is full of minority transplant surgeons who are outstanding transplant surgeons. I'd like to just ask a couple of questions to get started. I'm sure the number of people who have other questions, and I know Kevin is maybe one of them, but one of the things that I recognized at least 20 years ago was that there was a green screen in liver transplantation, which was problematic in the sense that if you didn't have money, you didn't get on the waiting list, and if you didn't get on the waiting list, you died. Is that any better now? I mean, for example, there was a time when Medicare didn't pay for end-stage liver disease and transplantation for liver transplants. I believe they're doing it now. Question is, are many of the Black patients getting actually on the list, or are they still dying because they can't afford to get on the list?
I mean, I think, Dr. Callender, your question hits upon a major issue, right? And I think one of those major issues would be is the and it's a whole nother talk for a whole nother time. When the Affordable Care Act came in, you have differences in access to insurance depending on what state you live in. So, for example, in Alabama, we would transplant anybody who had insurance of any type, whether it was Medicare, Medicaid, whatever. If we could get their insurance to say yes, we would transplant them. And it was just a matter of insurance in Alabama, and even in Maryland, and definitely at GW, was always a yes/no question. Like, I'm not interested in payer mix. I'm trying to get this institution here to not really pay attention to payer mix. And what payer mix is looking at private versus public insurances, because not all insurances, they reimburse the same. Let's be honest. I mean, medicine is a business in a lot of ways, right? And you have to be, the last thing that we or any hospital can do is provide 100% free care, because then all of a sudden it will all go, you can't stay open. The lights don't stay on because the electric company's not giving us free electricity. So I think, and so when you look at this, so for example, in Maryland, I was shocked, because you could take a patient who had no insurance, and we could usually find them insurance, and Medicare would pay for it, and they could get transplanted, which was amazing to me. Because in Alabama, if you came in and you didn't have insurance, you weren't going to get insurance, and you probably had 2 years or so to wait before we could get you insurance, because it's non-ACA expansion state. And so that's the other thing that kind of plays into these disparities, right? When you have places like New York, which is relatively liberal, New York, Maryland, which are relatively liberal with their insurances, and then you have places like Alabama, Mississippi, Georgia, which are not, those patients are a disparity also. And then even here in DC, you have a unique disparity with DC Medicaid in particular, because DC Medicaid at Maryland Hopkins, they can't take DC Medicaid because of the capitation. There's a higher Medicaid rate that everybody pays in the state of Maryland, and DC Medicaid wasn't willing to pay that, is my understanding. And then you have another institution, which remain nameless in the city, which looks at payer mix and wasn't necessarily very interested in that Medicaid patient population. And so that forces you really to look at the Virginia programs. And again, Virginia is not a part of Maryland, not a part of DC. And so their ability to take a bunch of DC Medicaid was a problem. So I think that's another part of the GW mission is we're not going to be interested in necessarily payer mix. So DC Medicaid is definitely something we're interested in. And I think we can build a good program, just addressing that disparity, those patients who typically were not evaluated. And I suspect there's also maybe not evaluated, under evaluated, or even slow walk evaluated, where, we'll evaluate you, but you're gonna have to wait a month or so to get into clinic. Well, with liver transplant, that can make the difference between being a candidate and not being a candidate, or being alive and not being alive. I hope
Thank
that
you
answers
very
the
much.
question.
Yeah, that answers the question. Are there other questions for Dr. Gray, who's presented so eloquently today on the issues of end-stage liver disease, and particularly how it relates to us as African Americans? Any other questions?
Dr. Gray, hi, this is Kevin. Thank you, Dr. Callender, for getting him out here. I'm a patient at Hopkins. That's the choice I made. I didn't, maybe if I would have known you, I would have went with Georgetown. But I was told my MELD score is 10, and that you're too healthy to get on the list, and that my only option is to find a living donor. And so one question is, can I get on the list? Another question would be, in the meantime, what do I do in regards to taking care of myself in regards to like nutrition? And the third question would be, as far as finding a living donor, I was always under the impression it was like no risk for them. But I'm hearing from you, it is a risk. So
Well,
those are, I guess, my three questions.
So one, I'll start with I know all the Hopkins surgeons, and my sister actually that's where my sister actually donated her kidney at, and they are an incredibly good group of physicians. So I mean, you're getting excellent care.
Thank you.
I think that they're right though with the score of 10. Your likelihood of getting a deceased donor transplant, they could put you on the list, but your likelihood of getting an offer with a score of 10 of an organ that's usable is incredibly low, without knowing your blood type. I think that live donor transplantation is safe. Liver donation is safe. I wouldn't have done them in the past if I didn't think they were, but it's not what really took off with kidney live donor kidney donation is that when people were able to have it done laparoscopically. I think that made a huge difference, because then patients were like my sister. So she donated, I think, the second or third week in December, and she helped her husband drive to Michigan 2 weeks later. Whereas with the liver, it's an open incision, and it takes around 4 to 6 weeks for them to really recover afterwards. And then there are complications that can associate with the donor, because of surgery. But any surgery is like that. So there's always risks associated with it. And I think that every time, and then I'm sure that you spent some time on Google, and every time in which live donor really starts to take off in the United States, there's potentially a donor death or a donor problem, and it's usually high profile when it happens. I mean, they usually a living liver donor dying post-transplant or having a major complication post-transplant makes CNN usually. And so that's a problem. Whereas the other places in the world where live donors really taken off, I spent time in Korea learning how to do live donor. I know my partners at Alabama spent time in Istanbul learning how to do live donor. There are places in which the deceased donor was really not an option. And I think that, societally is where the issue is that, we in America really want healthcare that has guaranteed outcomes with minimal risk. And live donor is one of those things there's really no benefit to the recipient, to the donor, except for helping the recipient. And there's risk associated with it, just like with any procedure. So I think that's, it's a societal question, I think, is to really when live donor takes off. I think the technology is there. I think the skill set is there. I think like places like Hopkins and Maryland and definitely Pittsburgh have shown that in Colorado have shown that it's safe, but it still is a matter of really taking off, and improving and shortening that length of stay, I think, for the donor. The other part is finding a donor, and that can be difficult. Usually, especially for guys, because of size. So sometimes that can be difficult. I think the places you start is with your family. And then they can say they want to be a donor, and then they have to send them for your case they'd send in a questionnaire to Hopkins and they get screened, and then they also talk to an independent living donor advocate, somebody who is only going to advocate for the health of your donor. And so that's, again, those are things which are all really important, and people and I think it's safe. You just need to go through the struggle of finding a donor.
Okay, and just that one last question as far as nutritionist. Should I seek out a nutritionist to make sure I'm on a certain diet, low sodium?
Yeah, I'd touch base with your hepatologist at Hopkins, if that's where your hepatologist is, and get them to plug you in with a dietitian as part of, if you underwent a transplant evaluation already, as part of that, there's a dietitian who's associated with that program.
Yes, she sent in a referral for me, but I'm just waiting to hear back from Hopkins. Thank you, though.
You're welcome.
I had a question, a couple. First of all, why would Alabama be more open to getting donations or actually doing the transplantation than other states? And the second question would be steatosis. I'd never heard about that, but by that name, I have heard about fatty liver disease. Maybe you could talk a little bit more about that too.
So I think that a lot of donation is driven by what we call the OPO, or the Organ Procurement Organization, and advertising and really getting out there into schools and churches and educating the public as far as donation. And they've done a lot of education down there as far as donation, and I think that's part of it. But I also think some of it has to do with when you look at Mississippi, because you look at the whole South, there's a lot of donation, a lot that occurs down there. So I think there's something about just culturally where donation is more accepted. As I think it's a community thing, right? So somebody in your community has the disease and people talk. I mean, this is probably, it's slightly stereotypic, slightly anecdotal, but it's like, we moved here from Alabama exactly 3 years ago for me to take a job in Maryland. I moved in on the 4th, a big moving truck out in front of my house. I didn't meet a single neighbor until June. Whereas when I moved in Alabama, I mean, like, we barely got our stuff ourselves out the car, and we had people bringing by cakes and pies and whatnot. It may have been because I was the only Black in my neighborhood, our second neighborhood, and so they were just trying to figure out who I was and make sure I was safe. But it's just I think you go to the grocery store, you stop at the gas station, people just talk, and I think it's culturally, I think it's just different. And then the steatosis piece of it. So fatty liver disease, again, steatosis is just a fancy term for fatty liver disease. You get paid more for saying steatosis. People think you're smarter when you say steatosis. It's usually it's a response. It's the body's response, again, to the hypercholesterolemia, so the high cholesterol, the hypertension, the diabetes.
Thank you.
Mm-hmm.
I have a question. Thank you, Dr. Gray. A very outstanding presentation. My name is John Tatum, and I had a liver transplant in 1993 at Howard University Hospital. And of course, Dr. Callender was on the team. But back around the time when I got my liver transplant, there was talk about famous people getting on the top of the list. You mentioned one earlier. You mentioned Mickey Mantle. But around that time, it was also Governor Casey of Pennsylvania, and another important actor that worked on a program called Dallas. He got to the top of the list. My first question is any of that going on now where big time stars are moving on the top of the list?
So I think that, in 1993, livers, I don't think things were not as regulated. And also, congratulations. That's amazing that you're out, almost a little bit over 25 years from your transplant. That's awesome. And that's what I always try and tell people,
28 years.
yeah. So 28 years. Sorry, I didn't want. Don't let me discount you by those extra 2 years. But I mean, I think that people forget how well recipients can do after transplant. And I think, the fact how you're willing to at least tell people that you had that, I mean, I think is amazing, because that helps. Nothing helps the donation process more than people realizing what that gift is, right? Because whoever your donor's family, 28 years later, they still know that their loved one is helping somebody to live their life. And so that's amazing. I think so. We are highly regulated as an industry. The advent of the MELD score, I think, really highlights the way in which organs are allocated. I would say that, on the small scale, there probably are occasionally people who, for whether or not they have, are potentially big donors or are famous or whatnot, they may jump up on the score a little. I mean, once an organ is allocated to that center, they may jump up a little bit, but in general, it's so highly regulated that there's really not a way to directly to cheat the system. I'm sure that, just like with taxes, there are people who play little games with their taxes. This time of year always upsets me because I'm trying to figure out who's obviously doing it better, because I don't think I'm doing it very well. But the system is very transparent and is highly regulated now. So I mean, I think that if it does happen, it doesn't happen nearly to the extent that it could in '93, when the system as a whole was not nearly as organized.
Let me make a comment about that, because I was around then. And as a matter of fact, I was on the Oprah Winfrey show, and they brought up Casey's case. And actually, what people didn't understand is that if you need more than one organ, then you jump the queue.
Right.
And in Casey's case, he needed a liver and a heart. And so as a consequence, he was transplanted earlier because he needed more than one organ. And of course, that fact wasn't brought out even on the Oprah Winfrey show. But that was one of it. And then with Mickey Mantle's case and the other cases, very often there were other reasons why people jumped the queue, and it wasn't related necessarily to their the fact that they were people who were noted and celebrities. But as you have stated, most of those issues have been addressed, and so that can't happen anymore.
Well, I mean, I think the other thing, Dr. Callender, would be how now I think most people also realize how if you transplant a celebrity, the first thing that's going to happen is somebody's going to kind of look at it, right? Because even within the transplant community, there's questions as far as the as far as Steve Jobs transplant. I think that'd be the most recent high profile transplant that I can think of, is to how the organ was allocated and things of that nature with him. But again, I think that, as a whole, the community has, we've done a pretty good job of self-policing when it comes to that. And then, I can think of even with when Diethelm got his transplant, he took a Hep C positive organ. So again, a lot of times people were willing to take, if you're willing to take an organ that wasn't going to be used anyplace else, that can jump you on the list. One of the other issues to kind of bring up with that is how really center aggressiveness, every transplant center is not the same. So center aggressiveness or even surgeon aggressiveness can really dictate who gets, how quickly you get transplanted also. So, any other questions?
Yes, Dr. Gray,
Go ahead.
I was just concerned, after transplant, can you talk a little bit about maintenance and the medication that's required? Are transplant patients on medication for the rest of their lives?
The screen is frozen.
Yes, just give us a minute. It'll come back up.
Okay.
while he's frozen. Yes, they do have to take medications for the rest of their lives. We're hoping that we'll get to the
Recording in progress.
You back, Stephen?
Yeah, I don't know what happened. I just tried to jump on my phone also, and all of a sudden I saw you weren't moving anymore, and I was like, oh crap. So
Did you
hear my question?
no, I didn't. I'm sorry.
My question was, could you address a little bit about the maintenance of a transplant organ and medication? And is medication something you have to take for the rest of your life?
So yes, you're probably going to be on medication. So when you leave the hospital, you're going to be on a lot of medication. And then slowly after transplant, we start weaning you off of your medication. There are places, one of the things in transplant that we always try to get to is the least number of medications possible. There are some people who on their own, without necessarily our consent, get down to like no medication, but most patients are on, we don't advise that at all. Most patients are on 1 to 2 medications specifically for their transplant, for the rest of their life. And again, from an insurance standpoint, that's where a lot of the risk kind of comes in, is that the expense comes in for them is maintaining you on the immunosuppressants. And then also I'm sorry.
I have a question related to that.
Yes, thank you.
Is there any, are they working on medicine and trying to deal with the immunosuppressant, in other words, working on medicines and different techniques to try to bring the medicine regimen down some?
We're all looking at it. I think, especially when I did pediatric transplant in the past, and we were really trying to get to tolerance. That would be where your body accepts the organ without necessarily taking any immunosuppressant medication. The problem with that is how tolerance is very much is like walking a tightrope, where like a little bit of wind, a little infection, a cold, anything can kind of tolerance is not, what we found so far is how tolerance is not like a destination. Once you're there, you're going to stay there. It's kind of like it's a moving target. And so, I think that there's been a lot of focus on trying to give people the least amount of immunosuppression that they can, really monitoring their levels, because as you know, there are complications associated with the immunosuppressants. But I think, right now, especially, now with the tacrolimus-based immunosuppression, most liver transplant patients within the first year to 2 years after transplant are down just to taking tacrolimus alone. And that's generally what my goal is to get people down to just taking tacrolimus alone.
I have a quick question about the latest research with the new mRNA technology. Has there been any studies of how to knock out the body's rejection?
Well, so I think I think when you start talking about the genetics, that's really when you start seeing what they're doing in xeno, and that with the pig transplants. And that's what they did. They went in and they knocked out a number of genes that the body reacts to in order to allow standard dose immunosuppression to work with those organs. Part of this is, from the time in which the organ is offered until the time in which we do the transplant is usually somewhere around 6 to 12 hours or so. So you don't really have a lot of time to go through and to do any genetic modifications of that organ or of you. So I think that, where you're going to see genetic modifications that are probably going to be in xeno initially. I think there's probably going to be some newer immunosuppressants that are coming down the pipe eventually, but we're not there yet. To really get to that.
This is not a question, it's really a comment. Listening at your presentation, I heard you say that as far as the alcoholism, you all changing from waiting the 6 months or beginning to change from that 6-month period. And I kind of just applaud that, because that was the reason my son did not get his transplant, because he was not able to wait that 6-month period. Right. And so I applaud the hospital for coming up with this new program to kind of reach out to anyone.
Yeah, I think what you're going to see over time is, I think how we're going to, as a community, I think we will come up with real criteria. For example, right now you have centers that are aggressive and centers that aren't aggressive, and so each center is kind of is on their own. Within the state of Ohio, they actually have an alcohol consortium. And so every center in that state actually uses the same criteria for that. And I think that really helps when it comes to disparities. Now, the disparity that's created is how, Cleveland's not that far from Maryland. So we transplanted around 3 or 4 patients who've been turned down within the state of Ohio at Maryland, but they were paid, and again, it highlights the problem when you have disparities in unequal access to a constrained resource, is that the patients with money travel. The patients without money or without knowledge or without access, they die, or they have to stay where they are. And so again, I think that's the area which we really need to focus. That's one of the areas that we really need to focus on.
Hello, doctor. I wanted to make a statement and ask a small question. I was surprised to hear. I got a lot out of this presentation, but I was surprised to hear that you couldn't be too old or too infirm to be on the transplant list. Because when I turned 60, I became diabetic and treated with medication, and have high blood pressure and all those things. I took myself off of the list on my driver's license, and I had started to try to find out information about willing my body to a hospital medical school so that I could still be of some use. I don't have children or a husband, so I did not want to leave um, somebody to have to pay for a burial where I might be of some use. So it's enlightening to me to realize that you can still donate. So when I get my license the next time, I'm 70 now. I think I'll check that box again.
So I guess, so just to clarify, we're saying how there's to be a deceased donor, there's really no upper limit. There's no, I would not take myself off the list. I think I would allow the OPO, the Organ Procurement Organization, to come in and evaluate and see if something is transplantable or not. There is, to be a candidate to get a liver transplant, there definitely are frailty markers and physiological things that could take you off the list. But to be a donor, I've used a 78-year-old liver before, and it worked well. Does it work well for every patient? No, but in the right setting, it can work very well. And so it's really important that we, that the tests are run and we don't automatically disqualify ourselves for things which could potentially be beneficial.
Dr. Gray, I have first of all, I want to thank you for your presentation. It was very informative. I have learned a lot from it. I had a couple of questions that dealt with non-alcoholic fatty tumor, and you answered those very well. And my next question dealt with the young lady who gave who presented the question on age. I also am a donor, and I am a registered donor. And I was very concerned with the age limitation of being a donor. And I want to thank you for the explanation that you gave. And now I feel secure that I'm still eligible to become a donor. Right now, I will become 71 years old this month. So it's good to know that I am still eligible to become a donor.
Well, thank you for registering. And I think, again, it doesn't, hopefully you live a long life, and you know, and you're never in a position where that's something that people are approaching you with. But again, it's like, you know, the organizations that help us find that find the organs, they have a whole workup and a whole bunch of tests and all the rest of that stuff that they'll go through. So I mean, I think that but that at least saying how you would be, you're willing to have your body at least evaluated for that, there's very little harm, or there's no harm associated with that.
Thank you.
Mm-hmm.
Thank
I have
you
a
very much.
question.
Okay.
My husband had hepatitis C. Apparently, he had it as a very young child. Over the years, many years later, he developed primary sclerosing cholangitis. My question is transplantation the next step after getting that disease, or is that something that can sometimes be treated through medication? Years ago, when he had his first transplant at Howard University Hospital under Dr. Callender in '96, it appeared that primary sclerosing cholangitis was somewhat new. And at the same time, I think it was Walter Payton who had it, and my husband met him, and he was always an advocate for transplantation. But is transplantation the normal step, the next step?
I think so. You know, they will, you know, with PSC, there's medications that people try. Obviously, ursodiol, or I can't remember what the trade name is for that. But, you know, there's medications that people try, and, you know, it's whether or not you start getting cholangitis with the PSC, or if you start having or if you develop a small tumor or cholangiocarcinoma in your bile duct that's amenable to transplant, then transplant's the next step. PSC is really, unfortunately, a lot of people with PSC, they kind of have the smoldering course, and their scores oftentimes, unless they get sick with the cholangitis or liver infection, their score doesn't jump up high enough to get to transplant. But transplant is probably, you know, is usually is one of the steps, definitely, in taking care of people with PSC.
Okay, thank you.
Mm-hmm.
Thank you very much for a splendid session, and thank you very much for your questions. And we're deeply indebted to you for broadening our horizons and answering so many questions so well. And we just want you to keep up the good work, and let us know when you're open for accepting candidates.
All right, well, thank you, Dr. Callender. I'd like to actually meet you face to face one day once all this COVID is over. So it'd be great.
Yeah, it would be great. Okay.
All right.
Welcome.
Take care.
Thank you so much. Take care. And the group, thank you for being such a splendid audience and making us look so good in front of Dr. Gray.
Thank you.
I had a question, Dr. Callender. When I first saw you at the NIH, you were mentioning that the percentage of Black donors was so low compared to the recipients. Has that score changed?
Both have changed dramatically. By the way, John, I just got a call from Juliette Williams, who happened to be the person who was with me in 1996 when I gave that presentation. You'd asked about the nurse.
Oh, yeah.
And actually, she called me last week. And so if you need to get in touch with her or anything, when you go for your 100th donation, let us both know. Maybe we'll show up and surprise you.
Wow. Thank you.
Okay, well, see you guys next week. Have a good weekend.
Thank you.
Take
Be
care.
safe,
Thank you,
everyone.
Dr. Callender.
Thank you,
Thank
Dr. Callender. Take care.
Thank you.
Bye, Mary Ellen.